Hello and welcome to this 4-part educational series titled Hot Topics in COPD from Disease Phenotypes to Targeted Therapies. Each episode in the series will be dedicated to one of the following topics: the role of type 2 inflammation in COPD pathophysiology, current evidence for the use of biologic therapies in COPD, comprehensive evaluation of the disease and patient symptoms, and lastly, evolving treatment algorithms for COPD. I am Dr. Surya Bhatt, Professor of Medicine and Endowed Professor of Airways Disease in the Division of Pulmonary, Allergy and Critical Care Medicine, as well as the Director of the Center for Lung Analytics and Imaging Research at the University of Alabama at Birmingham. Thank you for joining me. Let's begin. Let's start with where are we now with COPD. It remains a major public health problem. Globally, it's the third leading cause of death. Unlike cancer and heart disease, for which the mortality has consistently declined since the 1960s, COPD remains the only chronic major disease for which mortality continues to rise. It seems to have plateaued a little bit in men, but in women, it continues to rise. And tobacco smoking is the number one cause of COPD in high-income countries, accounting for more than 70% of cases. In low and middle-income countries, tobacco smoking accounts for a smaller proportion, 30 to 40%. And increasingly, it's recognized that there are other exposures that can cause COPD. In low and middle-income countries, this could be biomass fuel exposure. In both high-income and low- and middle-income countries, indoor air pollution is increasingly recognized as a major risk factor. With the population aging, models are projecting that the number of cases with COPD will continue to rise as much as 23% going from 2020 to 2050. In the United States, it's currently the fifth leading cause of death. The prevalence is about 6.5%, which translates to 14.2 million individuals with COPD as of 2021. And the prevalence is higher among women than men. There's no cure for COPD. Treatment is still aimed at managing symptoms and preventing exacerbations, as recommended by the GOLD document, which considers two axes of management. One is for symptom control, and one is for exacerbation reduction. Thankfully, the number of pharmacotherapies is expanding with the goal of targeting underlying mechanisms of disease, in other words, precision medicine. So there's now a better understanding of the inflammatory pathways in COPD. COPD has always been thought of as a predominantly neutrophilic-driven disease, mainly via the T1 and T17 pathways. But now it's increasingly recognized that just like in asthma to some extent, type 2 inflammation also occurs in COPD. And it's recognized now that approximately 20% to 40% of patients with COPD have underlying predominant type 2 inflammation. This is characterized by a variety of type 2 cytokines, predominantly interleukin-4, interleukin-5, and interleukin-13. And these are produced by Th2 cells and innate lymphoid cell type 2 in response to upstream epithelial-derived alarmins such as interleukin-33, TSLP or thymic stromal lymphopoietin, and interleukin-25. Let's go through the pathways a little bit. So in response to a variety of insults such as cigarette smoke, air pollution, allergens, viruses, bacteria, all of these can trigger release from the epithelial cells of what are called alarmins or first response cytokines. These are mostly interleukin-25, TSLP, and IL-33. These alarmins can trigger inflammation along two pathways. One is predominant neutrophilic inflammation via the T1 and T17 pathways, wherein dendritic cells, on accepting signals from these cytokines, can convert Th-naive cells to Th1 cells or Th17 cells, which then predominantly trigger neutrophils, and these can release elastase, causing emphysema, or TGF-alpha and elastase, causing goblet cell hyperplasia, or they can cause polarization of macrophages from the benign M0 to the M2 macrophages, which can then cause peribronchial or fibrosis. This has all been known knowledge for some time, but in the past several years, there's an increasing focus on type 2 inflammation. Again, it's unclear why some individuals progress along type 2 with the same exposures, and some others progress along the T1, T17 pathways. But for some reason, some individuals, 20 to 40% of individuals, have a predominant type 2 inflammation wherein the alarmins stimulate the dendritic cells to then stimulate the Th-naive cells to go along the Th2 pathway and then trigger the release of Th2 cytokines, which are interleukin-5, interleukin-4, and interleukin-13. The alarmins can also directly stimulate the innate lymphoid cell type 2 to release interleukin-5 and interleukin-13, or they can stimulate the mast cells to get degranulated, which can then directly cause smooth muscle contractility, or they can stimulate the eosinophils via the IL-4 and IL-13 pathways. Once these Th2 cytokines are released, Interleukin-5 predominantly acts by causing increased maturation of eosinophils, which then release interleukin-5, and then that can set off a vicious cycle of IL-5-driven eosinophilic inflammation. The other cytokines, IL-4 and IL-13, are now increasingly recognized to be quite important in COPD pathogenesis. They can directly stimulate basal cells to release MUC5A and increase goblet cell hyperplasia and mucus hypersecretion. They can result in barrier disruption in the epithelium. They can again cause the macrophages to get polarized from M1 to M2. And they can also directly stimulate smooth muscles, especially IL-13, to increase smooth muscle contractility. And all of these can, in consequence, result in peribronchial fibrosis. There is some evidence that eosinophils can release cathepsin L and cause emphysema as well. And the IL-4 and IL-13 cytokines can also stimulate B cells to switch classes and make more IgE. Overall, all of these cytokine effects can result in impaired epithelial barrier function, airway hyperreactivity, mucus hypersecretion, airway fibrosis and remodeling, and as a consequence of all this, lung function decline. So are there ways to detect these patients with type 2 inflammation? Well, clinically, it's very hard to discern who has predominant type 2 inflammation. You may get some clues, but they're not specific enough. For example, atopy, allergic rhinitis, patients having nasal polyps, but these are not enough to detect these patients in clinical practice given the non-specificity and the significant overlap in these pathways and some pathways in COPD. Individuals going through frequent exacerbations, that might be a clinical clue that patients may have type 2 inflammation, at least something you should look for in people with frequent exacerbations. There are also now increasingly recognized T2 biomarkers in the form of eosinophils, most commonly in the blood, but you can also look for sputum eosinophils. Rarely, if you happen to perform a bronchoscopy, then bronchoalveolar lavage or biopsy eosinophil levels can be also tested. Fractional exhaled nitric oxide, or FeNO, is a non-invasive test for predominantly IL-13-driven pathways. And the eosinophilia used in COPD is not real clinical eosinophilia, but it is a level that's slightly higher than usual. And the golden number seems to be approximately 300 cells per microliter, which is associated with increased exacerbations. Although the risk of exacerbation starts going up once eosinophils are above 100, and certainly above 300, there seems to be a marked rise in the number of exacerbations. People often term this as eosinophilic COPD, but perhaps that term does not convey everything that's going on in the COPD lung, and perhaps there's more pathways involved than just eosinophils, as I described. And during exacerbations, it's been noted that there are a higher number of eosinophils in induced sputum and bronchial biopsies. So although it is a reflector of type 2 inflammation, perhaps eosinophils are less directly pathogenic in COPD compared to, say, asthma. And it's important to remember that stable state type 2 inflammation, when they get exacerbations, it's more likely that these individuals will also more likely have type 2 related exacerbations. Not always, but are more likely to have that. And having type 2 inflammation predicts a better response to glucocorticoids, and now with increasing evidence also to targeted biologics. And T2 inflammation represents a feature amenable to therapeutic intervention. In other words, this is a treatable trait. Treatable traits can be identified based on the phenotype and or the endotype using biomarkers. The GOLD document from 2024 highlights two key treatable traits in the treatment algorithm. One is dyspnea and the other is exacerbations. And the effect of inhaled corticosteroids in exacerbation prevention correlates with blood eosinophil count. At around 100 cells per microliter of eosinophils, the response to inhaled corticosteroids seems to be better than those below 100, and certainly again at around 300, the response seems to be markedly better for exacerbation reduction. And treatable traits can also coexist in the same individual, so it's very important to look for a variety of treatable traits which can be simultaneously present and simultaneously treated in a given individual. So this brings us to a new class of molecules called biologics, which are a class of drugs that are produced using a living system, such as a microorganism, plant cell, or animal cells. And these biologics aim to target disease endotypes, meaning those which are identified via specific cell signaling pathways, as you can see in this video. So in summary, it's important to recognize the endotype of predominant type 2 inflammation. Clinically, this can be hard to detect, so one should have a low index of suspicion in people with frequent exacerbations and check available biomarkers. Most commonly and easy to acquire are blood eosinophil counts and fractional exhaled nitric oxide, or FeNO. And now there are specific treatments available for T2 inflammation, including inhaled corticosteroids and now biologics. Thank you for joining me for this Hot Topics program. You can view other episodes from the series on the landing page. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. Lastly, please remember to take the post-test and fill out the CME evaluation to receive your credit.